Hello, everybody. Welcome to our final session. My name is Jenna Heitz, and I am very grateful that you're here and that you've been able to attend today. We've just had some fantastic speakers, and we are coming into our final session where we want to offer you just a chance to reflect, a chance to look at our national and our state resources and opportunities for adopting this, for implementation, just for support as you think about this framework and moving forward. All of our announcements for housekeeping that we've made through the entire conference still stand. I will be your moderator in the chat, so please feel free to ask any of those questions. Any announcements I'd be happy to take care of there. We have today with us our expert for our state opportunities that he's going to be sharing with us. Again, our director for the Office of Mental Health Psychiatric Bureau Services, as well as our director for our Suicide Prevention Center for New York, Dr. Jay Carruthers. And we also have another distinguished guest joining us, Ms. Jan Ulrich. I'm going to take a moment to introduce her because she is here on behalf of the Zero Suicide Institute, which is one of our partners that we're very happy and excited to be always working with. Ms. Ulrich is a senior project associate, excuse me, for the Zero Suicide Institute of the Education and Development Center, which is where the Suicide Prevention Resource Center is housed. They also are the hosts for the Action Alliance for Suicide Prevention that you may be familiar with. She has 18 years of experience in the suicide prevention field, both professional and personal. Some of her story that she has allowed us to share with you, beginning in 2002, a few weeks after the death of her son, Nathan, Ms. Ulrich provided ongoing leadership and advocacy and action to the newly formed Kentucky Suicide Prevention Group. 6 weeks after her son's death, Ms. Ulrich and her husband, Steve, went to Washington, D.C. to participate in the Suicide Prevention Action Network annual conference and Day on the Hill, speaking to her senators and legislators about the devastation of suicide, loss, and the need for providing more prevention services. Prior to working for EDC, Ms. Ulrich spent 9 years as the Kentucky Department for Behavioral Health, overseeing a full continuum of suicide prevention across the Commonwealth, working with primary and secondary education, behavioral health, law enforcement, fire departments, emergency dispatch, trauma-informed care, workforce, college and the NCAA college athletics, legislatures, media, and others. Under Ms. Ulrich's leadership, Kentucky became the second state to require behavioral health professionals to receive ongoing clinical training in suicide care. Under her leadership, Kentucky was also one of the first states to require both training for middle and high school educators, as well as middle and high school students. That's a lot, and I can tell you, I saw it firsthand. Ms. Jan Ulrich also led Kentucky's first steps into zero suicide in the healthcare systems prior to coming to EDC Zero Suicide Institute. Kentucky became one of the first states to crosswalk their vital statistics data with suicide death among individuals who were seen in community mental health systems in the state within a defined period. Ms. Ulrich created the prototype of the Zero Suicide Organizational Self-Study, a tool which you have heard talked about during this conference, and it allows you to assess the level of suicide care in health and behavioral health care systems. Prior to joining the Institute, Ms. Ulrich possesses significant experience managing projects, delivering consultation and support. I am extremely excited to introduce my colleague and friend, Ms. Jan Ulrich. Thank you.
Thank you, Jenna. I wanted to talk a little bit today about this opportunity coming up around a learning community or a community collaborative. So what is a community collaborative? The opportunity to share information back and forth and to walk through an initiative that you're trying to accomplish, as in the aim for zero suicides, but be able to go in it when you're not alone, to be able to share that information. Just a little bit of background, as Jenna just said, I come from the Zero Suicide Institute, which is part of the Education Development Center. We also, in addition to housing the Zero Suicide Institute, we have been leading the Suicide Prevention Resource Center since its inception with a grant from SAMHSA, the Substance Abuse and Mental Health Services Administration. And we also play a large role in the National Action Alliance for Suicide Prevention. But talking about what is the Zero Suicide Institute, we really provide expert training and consultation to both healthcare and behavioral healthcare systems in this systems approach to be able to dedicate time to having really safer suicide care. So you have an opportunity after this event to get involved, with this community of practice. We've been doing communities of practice or learning communities for a long time at the Zero Suicide Institute, often following after Zero Suicide Academies, et cetera. And the idea is to be able to bring teams together, organizations together that are able to both learn new things, but also to share information back and forth. A learning community is when a group of people are really wanting to go towards a same outcome and share that concern or passion around something, as many of us, maybe all of us do, around zero suicide, around reducing the number of suicide deaths that happen in our states, in our communities. And so that learning community has a chance to both take in like formal teaching, take in new information, and then also to continue to share that information among each other, really sharing your challenges, sharing your successes, and in that way being able to actually push ahead in a way that you might not if you're going to do this on your own. So talking about what an objective to a learning community might be. For this particular learning community, we're talking about helping to sustain and support safer suicide care, helping build capacity for those who are involved by sharing those successes and resources and lessons learned, and then also have the opportunity to bring outside expertise to the table and consultation to the table. So taking the information that you're learning today and over the time of this conference, this Aim for Zero Suicide event that has brought so much valuable information and knowledge, the learning community, the community of practice is going to give you that opportunity to really start putting in place an implementation plan, to have a better understanding of what all the steps are that organizations like Henry Ford Health Systems and others have been doing to have the type of success that they've seen. And that's really part of the purpose of doing this. Some of the other things that you'll be able to assist in is really look at some ways to participate. Part of it might be solving problems that you have identified in your particular organization. You might be working with your electronic health records and trying to figure out how do we make our electronic health records really help us in this initiative, in this Aiming for Zero Suicide initiative. And you might have the opportunity to find out that there are others within that learning community or community of practice that are working with the very same electronic health records and can say, here's how we did this and here's what works for us, and we're glad to share that information or knowledge. You can reach out and ask other folks that are involved in this community of practice Where can I find more information about grants and prevention work? And so there's a lot of different ways, and you'll see some of these on the screen, different ways to participate within that learning community, within that community of practice environment. And in addition to that, when you form sort of that solid structure, that solid learning community, you may be able to reach out even between those monthly opportunities to come together, to hear from experts, to hear from each other, to hear how we overcame different challenges. And so I really do encourage you to consider signing up for the community of practice. I think if your organization is serious about, really aiming for zero suicides, really looking at how in your healthcare or behavioral healthcare system, or your system that crosses paths with health and behavioral healthcare systems and individuals that are at risk, then this will give you an opportunity, I think, to move many steps ahead and to have that expertise and knowledge and shared opportunity both during those events, during those virtual events, and in between those events, being able to reach out to each other via emails or phone calls to say, I want to know more about what you and your organizations are doing. And at that, I believe, turn this over to Jay.
Thanks, Jan. Okay, so I'm gonna talk, maybe some of you caught Brian Amadani's fantastic talk just before this one. And he made reference to a lot of the work that has been done in Michigan. And I'm happy to report that there's been, we have a proud history here in New York State as well. Of doing zero suicide related work. There have been major contributions made by New Yorkers. And so I'm going to talk a little bit about the evolution of that work. And then we'll kind of, we'll at the very end, we'll share some resources for those that are hopefully going to go back to their organization and engage other people around doing this work in the future. So, all right, so first, though, I do want to just start out by acknowledging it's absolutely a team endeavor, suicide prevention, and it's really your collaborations and connections with others that are going to get you through. And so I just want to highlight some of the folks on my team. Again, Jenna Heiss has really done a fantastic job spearheading this symposium. Kara Brzezinski, also others on the team here at the OMH Suicide Prevention Center. Our commissioner, Commissioner Sullivan, has been a champion. Our partners at the Center for Practice Innovation, that's where Barbara Stanley and her group, which is SPTI, Suicide Prevention Training, Implementation, and Evaluation Group. And we'll, at the end, I'll list some of the resources and trainings that are available that Barbara's group has developed. We've also collaborated with the Psyches team here at the Office of Mental Health, and I'll talk a little bit about that project in a second, and many, many others that too many to list here. But again, we started this day kind of honoring and celebrating the accomplishments of some of our grant sites and our advisory council, but I think it's important to really take time out to acknowledge those that are doing the work. All right, so our work has really been guided. This is sort of our blueprint. This is the state plan, the suicide prevention plan that we call 1700 Too Many, because this was actually based on 2014 data. When we ran the CDC data at that time, at that query, that point in time, there were exactly 1,700 deaths attributable to suicide. So this is the report that we issued in 1617, and I haven't counted them myself, but each one of those dots in the silhouette of the state of New York really represents, it's not just a statistic. You heard a bit, these are impacting families. It's someone's husband, father, brother, wife, colleague, friend. So, really impacting our communities. And you heard a little bit about Jan's story. I also actually, a couple of years into taking the director role for suicide prevention here at OMH, I lost my brother to suicide. So, it impacts so many of us. And so it's important to never lose sight of that fact. Really, it's easy to kind of depersonalize it with the statistics and the abstractions, but here, what lays out kind of our approach that's guided our work over the last several years, and really pillar one. I'm not going to go into the other pillars, but we very much do a lot of community-based work in schools. Data and surveillance is obviously crucial. But the focus of today, of the conference over the symposium over the last 3 days has really been the zero suicide work. So I'm not, so just real quickly, I do think, this has been covered kind of sometimes tangentially, but people do get hung up on the name. I think it's important to recognize that it is both an aspirational goal, but also a set of practical tools that have been proven in the field. And you've heard about that a little bit from some of the presenters. So, and I do think I think Richard McKeon talked about it today, that we have to be sensitive. I think, what did he sort of said it, the name is really an assault on the fatalism of helplessness that we've assumed around suicide. But we do have to be sensitive to that. It can upset family members who have really done so much to try to prevent suicide deaths, and despite their efforts, still lost someone. So the domains have been kind of touched on, but I think, and you've heard this repeatedly, I'm just going to underscore that really has to be systemic in nature. It can't be kind of the heroic individual efforts. And again, I think that point's been driven home. But it really starts with, people have said, how do we start? Well, I think you do need leadership, explicit commitment from leadership to really reducing suicide attempts and deaths among those in your system of care. It's really that straightforward. It has to come from that, in my eye and my estimation. Those are the 7 domains that people have touched on, not really gone in depth, but I'm just going to repackage them a little bit, because that's what we did in New York. We have to kind of make it our own. That's we're sort of overly deterministic, as Mike Hogan said. So there are really 4 components that are clinical in nature among those 7 domains. That's identify, engage, treat, and transition. So we've repackaged those in something we call AIM, and I'll explain that. The other 3 are, I would say, are more systems. Really, that's where your leadership earns their pay. They're supporting you very visibly. They're training that caring, compassionate, confident workforce, and they're investing in the data quality improvement measurements of, like Brian Amadani's group. So critically important. Okay, so really quickly, and really the work what we've done is essentially tried to plug the Swiss cheese holes here by implementing care pathways, making sure we're doing systematic screening in New York. So I always like to reference this slide from Mike Hogan. We have done a lot of work in safety planning, which includes reducing access to lethal means. You've heard about kind of directly treating the suicidality. It's not enough to treat the underlying behavioral health condition. The evolution in the state of New York is really, kind of the original national strategy report came out years earlier. And then the National Action Alliance was really setting up a national advocacy group to really champion suicide prevention. We're proud of New Yorkers being involved in the Suicide Care and Assistance Framework report. Jenna Heiss was involved in Texas, and Fred Maservi and Gary O'Brien and others here from the original kind of founding members of the Suicide Prevention Center here in New York. And so, and then the second edition of the NSSP came out, and we got our first grant, National Strategy for Suicide Prevention grant in 2014 with SAMHSA, and we were on our way. So back to sort of repackaging some of the models. These are the clinical components that we've pulled out. we've kind of, Barbara Stanley is credited with kind of repackaging and really sort of highlighting, pulling out the clinical components and what she referred to as AIM. So assess, intervene, and monitor. I think it's a helpful framework to kind of really prioritize what the clinicians need to really have a good handle on and feel confident and competent in delivering. So, assess, systematic screening and assessment. Intervene is really evidence-based interventions. And we have, in part because Barbara's here in New York State and a close collaborator, we've really emphasized that, but it's a brief intervention that it's not as heavy a lift as some of the other modalities, like learning a full-blown psychotherapy, and it's evidence-based. So it can be deployed in a variety of settings. So we've been less successful getting consistent uptake in psychotherapies because I think it is a heavier lift. And then monitoring, we've done a lot of the evidence-based around safety plan includes follow-up phone calls. So we've been trying to model that here as well, mostly in our grant work. And this is the flow that we've had. We really have done it because the leadership has come from the Office of Mental Health historically. We're a series of commissioners and staff here. We started in behavioral health, really mostly the public mental health service system. A lot of our work has been grant driven, and we're really looking forward. And part of the symposium is an effort to get us beyond grant driven uptake of the zero suicide model. We really hope that you'll answer the charge. But initially, one of our largest projects was nearly 160 outpatient mental health clinics in the public mental health system that were either operated by OMH or licensed by OMH. And that's because our surveillance showed that was where a lot of the deaths were occurring, that many people had an outpatient clinic visit within 30 days of their death. You heard from Brian Amadani, that surveillance is critical. We've also done and the larger ones have been guided by the Psyches team. I need to give them credit. It's a resource that some of you may have heard of already across New York State. It's a platform that's kind of a decision support platform that supports best practices. And we've deployed it a couple of times in suicide prevention, both in the emergency room, high risk quality collaborative that's going on, which is a violence towards self and others, as well as high utilization and overdose deaths. So not just suicide in that project. And we're currently, as our grant sites know, and really have been boots on the ground, we've got an intensive demonstration project in Onondaga County, as well as some other large systems across the state, and there's a zero suicide grant with SAMHSA. But really, we're kind of trying to pivot and position ourselves to do more scalable I think there's opportunity to really build equity into this work and for delivering, compassionately delivering evidence-based interventions. So that's and we're trying to push out from the behavioral health system into these other settings. We've started some early work in primary care. You heard hopefully Verna Little's talk on primary care yesterday. And so I think you are all cordially invited to participate in this work. I really hope some of the work I'm gonna and I hopefully some of the content provided in this conference has been helpful to that end. And we really do, like I said, we've been thrilled with the partnerships we've had up to this point, but we're looking forward to forging more. Both leveraging national resources like the Zero Suicide Institute and Jan and her colleagues, but also more local participants in this work. And I'm going to sort of close, and we can have sort of a little more discussion and any questions and answers, but want to make sure you're not alone in this work. There are resources. We hope some of you will consider the Community of Practice app. And so if you go to the Symposium Resource tab, you'll find some resources, including our implementation guide that was really based on a lot of our grant work, but also the application to the Community of Practice. And I'll just say a little bit about this. And Jenna, you can chime in and provide additional information if I'm missing. But we're looking for really large health systems that have that can get commitments from 3 separate focal points in their system of care. So emergency room care, primary care, and their behavioral health service lines. So we're looking, so large health systems that that have buy-in or have leadership in all 3 of those poles that are willing to participate in the community of practice, where we'll be bringing in subject matter experts from the Zero Suicide Institute and New York State, and doing basically a 9-month learning collaborative or community of practice. So that application is on the resource tab, as well, in addition to the implementation guide. Jenna, you can remind us sort of when the application is due. I don't have that information at my fingertips. Additionally, again, you're not alone. If you go to the Zero Suicide EDC website, I linked here to the movement, but there's a listserv. There's lots of ways of engaging in this work. So, and the suicide prevention website page here is listed as well. And then I want to also highlight the Center for Practice Innovation, Barbara Stanley's group, has a fantastic library of trainings, really rich trainings. Those are really right now accessible for OMH and OASIS licensed programs, but we are working on developing a portal that gives access to non-OMH license, so primary care, medical emergency room, and the like. So I want to thank everyone again for their time and engagement in the symposium, and hope that you'll certainly go back to your organizations and feel a sense of kind of renewal and energy around helping New York State continue to push this work forward. So I'm going to stop there. I don't know, Jan or Jenna, any further comments that you all want to say about the community of practice?
Hi, yes, thank you so much, both of you. This has been a fantastic overview, and there's a lot of exciting work to come, and a lot that's been done that we can all build on. Thank you both for your overview. We have a couple of questions. Excuse me. Yes, we have a question from a friend. Can you provide a little more detail on how healthcare providers or a group of providers could sign up for the community of practice, and what the cost would be? Oh, okay, I guess I can.
Wow.
Go ahead, Jay.
The cost is simple, right?
Yes.
It's free. It's a competitive application, so not all systems will be able to participate. We have to limit the spots. But I think assuming that you do have, if you're in a large enough system of care that you have colleagues in primary care and emergency room, then I think the best way to do it is try to strike up a conversation and share the application with those colleagues, and say that, talk about the symposium. You can even link to, if they're from the emergency room, you could link to Ed Boudreau's, to give them a flavor of some of what we're talking about. Dr. Ed Boudreau's talk. If they're in primary care, you could link to Verna Little's talk, just demonstrating great depth of knowledge and expertise in this area. And it would essentially be supporting your colleagues in the usual process is basically identifying, figuring out what you're listening to, figuring out what you're currently doing. You heard Brian Amadani talk about that. I think that is always the first step, is listening to what you're doing. All systems are always doing a lot, and then sort of identifying where the gaps are, and basically charting a course, bringing subject matter experts and each other, as Jan underscored. There are going to be 7 other teams, and learning from them, supporting each other over the 9 months, and trying to bridge some of those gaps. I don't know, any other suggestions, Jenna or Jan, in terms of how to pursue participation?
I would defer to Jan first, and then I do have some practical information.
I do know that the application is due November 15th,
Yes.
2021. as far as how to do this, I think, as Jay said, look at pulling together sort of that team sort of across the aisle that is going to be the most beneficial, provide the most beneficial care when you think about a person coming into behavioral health care or into health care in a suicidal crisis. And how do you make sure that you sort of have that well-rounded approach where people can transition from one level of care, go into a primary care provider's office and be able to know that any door is the right door. So a primary care office might, team up with a hospital system or with a behavioral health care system, just really looking at who are those shared clients that go between the different systems, and think about that when you put your team together.
Yeah, absolutely. And excuse me, since we've been able to do a lot of work, as Dr. Carruthers has already mentioned, with our behavioral health providers, and the goal of this symposium was really to initiate or perhaps just enhance knowledge across our healthcare providers in New York State. That really is the goal of this community of practice, is just to give folks the opportunity to meet monthly. It's a community of practice because it's not so much about learning about all the different components of how the national model is laid out in the framework, and then how New York has been implementing it in all the education and resources, because we know that you're able to watch things like this and go to the website yourself. But it's truly about how your specific agencies and organizations can come together, implementing these practices and sharing that cross information with one another, with the guidance of our New York team, but also truly with the experts. The Zero Suicide Institute has been doing this with healthcare systems and providers across the United States for many, many years, and they will bring in the experts, such as the folks that you heard today. They might bring in Brian Amadani or somebody from Kaiser. They might bring in Verna Little, whatever is needed to help the systems that apply. Do some work in each of the individual settings, which would include psychiatric services of some sort, as Jan said, across the healthcare system, kind of like what Henry Ford is doing, or Parkland Hospital in Dallas, for example, and some of these other systems where we've seen psychiatric services, healthcare, primary care, and emergency departments really working together to integrate this work across the system. And so, as Jay said, the application now has been put into the chat. Though we're asking you now, with any kind of, I don't know, kind of, while it's fresh in your mind, to look at the application, to start getting folks interested within your care system, and to put that together by November 15th. There are, like my phone number, there are the email addresses of those of us that are involved with that on the application to answer any other further questions. I find the application sort of, I don't know, easy to go through in the sense of you can just follow along pretty simply. It outlines and explains everything that you might need to know. The community of practice itself starts January 1st, so you have plenty of time to get through some busy seasons, the holiday seasons, figure out how you might do this within your system of care during the time of the pandemic and COVID, and how that affects healthcare systems. We want to honor that, very clear about that. And so it would start in January, and then it would run, as I said, monthly through to the end of September. So we would get plenty of time to kind of bring all these communities together and all these experts together, so that could be learned about and implemented. Excuse me. So hopefully that's it.
But for those that aren't doing the community of practice, if they're not going to apply, I think, again, there's lots of other ways of engaging.
Yes.
If you go to the Zero Suicide main EDC webpage. There's the organizational self-study that you can find as part of their toolkit, where, it's really, again, everyone, it starts with assessing where you currently are and identifying your gaps, and basically setting some, forming a team that's going to help you with this work, and then setting some goals on what gaps you want to focus in on. But it is, you do need a coalition of the willing. So you got to kind of have your powers of persuasion, and that's why I think, linking to some of the content in the symposium. I think the symposium page is going to be up for 30 days, or, if you need to kind of show that this is a serious commitment endeavor, that with subject matter expertise that's available for help. And you can also go to our, if you Google, the Suicide Prevention Center of New York, you can go to our page, you can hit the general mailbox if you want additional, consultation.
Yes.
So that's also available, a number of ways to do it. There's no one way, but.
Correct. And there's the Zero Suicide listserv that you can sign up through, the website that Jan just put up, made of, all kinds of folks. National experts are on there, as well as folks at the very beginning of the stage asking questions all the time. So there's just such a plethora of research and folks doing this across the country. So we want to end on time. So excited to have had you join us. Any final thoughts, Jan or Jay, before we close?
I think, I just think it's actually very rewarding work. I think you'll, really meaningful work. So, and I think you'll find that as you, that's been my experience. And I strongly suspect that if you do pursue it, you'll find the same. So, but I want to thank Jan and Jenna for joining me today, and hope everyone really enjoyed the symposium.
Absolutely. And I just want to give a shout out to, our behind the scenes team of our administrative assistant, Travis Serson, and of Greg, who is our communications director, and all those folks behind the scenes. So thank you. Wouldn't have been possible without them. And we are, again, very excited that you stayed with us and that we had this wonderful time together. Thank you so much. We look forward to seeing you out there doing the good work.
Thank you.
Thanks.